BP measurement we should use. So we know the ABPM is the standard, but it's just not possible every time to measure blood pressure. And home BP, we advise patients do follow. Sometimes they do measure. Then we don't know how the machine is accurate. Sometimes they measure, they don't write. They say everything was normal. And sometimes what happens is patients measure, they forget writing it, and they are sitting outside the consulting room and they are writing, they are scribbling everything, and they produce that, sir, BP normal. So home BP, however desired, is just not practical. So all we have to consider is an office BP, and office BP can be measured by standard mercurial that we use, or it may be semi-automated, the simple home-run machine that we use, or an automated oscillometric BP which was used in Spain trial. And what it does is it measures 3 times over a period of around 5 minutes. Patient is left alone in the room so that no other whiteboard effect will take over, and the 3 readings are taken and the machine displays the average of 3 readings, and it is considered a better method than the semi-automated oscillometric method that we use, because there is an added effect of whiteboard phenomenon. So what are the guidelines? Guidelines, ADA says that patient should be seated with the feet on floor and the arms supported at heart level, and after 5 minutes of rest, 2 to 3 BP readings are taken 1 to 2 minutes apart, and the average is taken. One single reading may not be accurate, so we have to take average BP when we are using oscillometric methods. NHS says that once a week patient should measure in the morning hours and in the evening hours, 2 readings at the same at the time, and take an average of it. So once a week it was burdensome to the patient. So what they suggested again is an alternative method, that daily for 7 days before the next scheduled visit to the physician. So daily he has to take BP 7 days before the next scheduled visit. So this is shown to be a same predictor of the once a week BP measurement. So coming to the question of ACE, or yes,
question of measuring the blood pressure. So you said oscillometric office unattended blood pressure measurements.
Yes.
Do you use in a clinical practice, and what machines you are using for that?
So we are using mercurial because we are more comfortable with that, and oscillometric needs more maintenance, which may not be possible every time. So mercurial, we are comfortable with that, and many studies have used mercurial method for the BP measurement.
Now mercurial BP apparatuses are being phased out because of
Yes. Yes.
But see, what you really have to do the oscillometric measurement, as Vipul said, the patient has to be sitting for nearly half an hour. He has to first sit for 15 minutes, then the readings, 3 readings are taken 5 minutes apart, and then average. So just the blood pressure estimation is going to take this patient 20 to 30 minutes.
Yes.
How many patients are going to agree to that is the real question.
And
Also in the overweight patients, I don't think the rubber cup actually covers 3/4 of your arm. They don't even get to half, and then it keeps coming out the velcro. So I'm not really sure.
so
Too fast the pulse, atrial fibrillation, and too slow pulse will require a wrong reading in blood pressure. You have to be careful in the arrhythmia patient. You can't use these machines. But all the studies, Sprint study, they use this machine. They use the same machine.
So there is a study which says the home monitoring of blood pressure was as equivalent to the ABPM.
Yes.
When you do it right way. So, but your method, your machine should be approved.
Machine should be.
And that is there in the British and Irish Hypertension Society. You have a approved machine for
Yeah,
that.
the Omron machine made in Japan is supposed to be a good one, and that is being used and validated for recording blood pressure.
with that
Yes.
non-mercurial
In fact,
BP
the
machine. I don't know what to call it.
Sorry?
Non-mercury BP machine is just
Uh,
like
L-
mercury, but it is
LCD.
that LED.
LCD,
like
LCD or LED? LED machines are available, that's quite accurate, but all those are compared to the mercury. So mercury is the gold standard, it is usually compared with that. The mercury is banned because of the toxic effects of mercury. All these fish and all used to eat mercury because there is no question of disposal of the problem. It also causes serious effects called man-happy disease. So therefore this mercury is banned.
So there is another machine which is called Microlife. This is promoting, approved by British Hypertension Society and NICE. What do you think about it?
If the machine is approved, certainly you could use it. And the point that Dr. Nehru mentioned, ultimately what is the unit in which we measure? Whatever machine you use, we express the blood pressure in millimeters of mercury. So every kilopascal. Kilopascal. So I think Vipul will have to go on. That's very important.
Yes, for diabetic person, postural drop is it is significant to measure that. It is important, and what I have seen is many of the physicians do ignore this aspect. In a patient who is on treatment or on diabetic, this is the most important thing that I would like to see, rather than considering other factors. So what about ACE versus ARBs? So going by the pharmacology, they are expected to have the equal effectiveness, but the statistics are going in favor of ACE inhibitors, because ACE inhibitors were used in larger studies and they have shown a lower mortality, but same was not the case with ARBs. There may be multiple mechanisms. The inhibition of ACE2 and the production of ANG17 may be responsible for that, but we really need a long-term comparison study between ACE and ARBs.
ACE so, just higher doses, higher doses of ACE,
yes,
not a lower dose. That's very important.
Yes. And those who get cough may be related to those, but it's usually some patients do get it. It may be idiosyncratic reaction, and that bradykinin overactivation happens in every patient, but some patients do get cough, some don't get, and it is probably an idiosyncratic reaction. And those who get cough with ACE inhibitor, they tolerate ARBs well, but not is the case of angioedema. Angioedema, there is a lesser risk of ARBs, but some patients do get angioedema even with ARBs. And hyperkalemia risk is safe, and which is the major impediment in using these drugs. So BP or proteinuria. So the drugs that we are using for antiproteinuric measures, ACE inhibitors, cilnidipine, diltiazem, and others, are weaker antihypertensives. They do not achieve that good control. So BP control is more important than the proteinuria, because if you go by the physiology, controlling BP will control your intraglomerular hypertension, which we try to achieve by giving ACE or ARBs, and that controlling intraglomerular hypertension will itself lead to reduction in the proteinuria. And as Dr. Lobo pointed out, BP is more strongly associated with the cardiovascular outcomes, and which is probably the commonest cause of death in diabetic patients. So BP is important. So the point that I want to make here is, if my patient is at around 150 BP and is having proteinuria, there is no point in starting cilnidipine to this patient. This patient needs better BP control. So probably a better drug, nifedipine, retard, or amlodipine will be a better choice than the cilnidipine, which is a weaker antihypertensive. If a patient is already on amlodipine with good BP control and there is mild slight proteinuria, in that case there is no point in shifting that patient from amlodipine to cilnidipine just to have that proteinuria reduction, because that will increase his BP and then there will be problems with that. So these are the drugs that control both BP and proteinuria: ACE inhibitors, ARBs, then dual calcium channel blockers, non-DHP calcium channel blockers, direct renin inhibitors, and probably beta blockers, because they do control BP. So this is everybody might be familiar. This is ADA recommendation that around 140 to 160 BP we start with one agent. With more than 160 BP we start with two agents. And here I want to concentrate about the choice of antihypertensive. So in patients who has albuminuria, ACE and ARBs become the first choice. And if patient is not having, then KDIGO suggests using them, but the other drugs can also be considered in that case. In patients who needs two drugs, the choice may be ACE inhibitor or ARB, or the calcium channel blocker plus a diuretic. And in an albuminuria patient, ACE or ARBs are compulsory, and either you use diuretic or a calcium channel blocker. So this is how the guidelines suggest that ACE ARBs should be the first choice, second the diuretics, then third calcium channel blockers and other drugs. The patients that come to us are already out of all these two drugs. So the first choice for a nephrologist becomes calcium channel blocker, and for me it becomes either nifedipine or amlodipine, because cilnidipine is a weaker antihypertensive. So if a patient comes early in the disease or presents to a physician, then the ACE inhibitor or ARBs should be the drug of choice. Diuretic may or may not be required in a particular patient. And then what I usually do is calcium channel blocker followed by either alpha blocker or clonidine, then followed by beta blockers and other if required, and finally the vasodilators. Yes.
Just wanted to know the safety of alpha blocker, because I see nephrologists have got model alpha blockers.
They have not been shown to be they are really safe. There is no data to suggest that there is nephrotoxicity.
There is no toxicity with alpha. Are you talking about selective alpha blockers? No, so those are, if you're talking about the group like tamsulosin, silodosin, those only act on the prostate and the bladder neck. So those are given for a different purpose, not for blood pressure control at all.
But it causes postural hypotension.
Very well, yes.
Amlodipine versus cilnidipine.
Yes.
What do you use?
So the evidences, if we compare all the evidences, the BP control is better with amlodipine, but proteinuria control is better with cilnidipine. And if you go into the details of this, all the literature that is favoring cilnidipine is coming from a particular part of world, Japan and China, and some from India, which may be somehow it may be pharma treatment. And secondly, what I would consider BP control is more important. That's why amlodipine would be my choice than the cilnidipine.
The control is quite good. Look at it for